Good morning and welcome. We're here today to explore the emerging therapies and show you what is in the pipeline. That we're going to go through the challenge of the current treatment and potential of TKIs, the use of TKIs in neovascular AMD, and we'll have a panel discussion. How will TKIs fit into our current therapeutic landscape? And a question and answer period. My name is David Boyer. I'm a retinal specialist in Los Angeles, and I'm joined by my colleague and friend, Michael Ip, from the Doheny Eye Institute. I am obviously have numerous disclosures, some of which will be incorporated into this, and this will be available online. Our learning objectives today are to discuss the current unmet needs of patients with neovascular AMD, describe newer therapies that are on the market or soon to be on the market, and appreciate the newer clinical trials demonstrating durability. This activity is jointly provided by Clinical and Patient Educators Association and iVista Medical Education, Inc. This activity is supported by an independent medical educational grant from EyePoint Pharmaceuticals. The content, however, is not influenced by the grantor. At the end of the program, an email will be sent to you with instructions of how to claim CME credit and print your certificate. Please use the question box below to send your questions and/or comments that we'll answer at the end of the presentations. Dr. Ip, talk to us about the limitations of current treatment.
Good morning, David, and thank you for that introduction, and hello, everyone. When I see patients with exudative age-related macular degeneration, I really think of two things now. One is how lucky we are to be in this current era where we are treating patients and we can expect, in many cases, improvement of visual acuity. But I also think of another thing, which is this is going to be a situation where we really have a high treatment burden. When I see this patient, I think we better start liking each other because we're going to be seeing each other quite often, right? If it's just one eye with exudative age-related macular degeneration, we're going to be seeing each other 4 to 6 weeks, and maybe we can extend it longer, but it's going to be over a course of many years. And if it happens to be bilateral, it's going to be even more. So that's, one of the things I think of in terms of how our treatment paradigm is a blessing, but it's also a limitation. And this is an excellent slide looking at this timeline of the development of where we are right now, where we came from and where we are. So David Boyer probably remembers this as well when we started treating patients with laser photocoagulation as per the macular photocoagulation study. And we would tell patients, we're treating you now, you're not going to see as well tomorrow, but you're going to see better in 5 years if we treat you compared with if we don't. And then we moved on with the TAP and the VIP studies for photodynamic therapy, and we got some improvement there. We had less 15-letter losers with photodynamic therapy, but no chance of visual recovery in most of these cases. And then we moved on to the FDA approvals of anti-VEGF therapies. Interestingly enough, the first one, which was pegobtanib, it didn't show an improvement, but we also prevented or reduced the proportion of 15-letter losers in the treated arms. And then we moved on to the next generation. We had ranibizumab, aflibercept, and then now sort of second-generation drugs with higher dose aflibercept and faricimab, where we're able to achieve those excellent results I was talking to you about. But it does appear that some of the limitation is durability and the burden of treating these patients. So I'm going to describe a number of studies in the literature that really drive home the point that there's a durability issue, there's a burden issue, and if we're not able to maintain what we need to do in these patients, which is sustained injections, there will be a loss of the initial gains that we see. So here is a slide which shows a comparison of randomized controlled trials on the left and real-world analyses. And you can see that concomitant with the reduction in the mean annualized number of injections that you can see on the right-hand side, there's also a reduction in the mean change in the vision from baseline to month 12. And this is an analysis of a number of RCTs on the left compared with real-world clinical evidence that you can see on the right-hand side of the screen. And on the top is sort of a summary of what I just showed you, with the real-world data having a lower number of mean annualized injections every year, with a concomitant reduction in the visual acuity. On the bottom, you can see that this is actually true for other diseases such as diabetic macular edema. And in this study presented by Frank Holtz and others at your retina, they termed it the Lumina study. It's been subsequently published, but you can see here that they looked at the number of ranibizumab injections up to month 12 in the first year of management in this real-world data set, and the majority of patients receive 5 or less injections in the first year of management, which is much less than what we would see in the randomized clinical trials, where you see these fantastic gains in visual acuity. Tom Shula and his colleagues looked at the Vestrum database, and you can see that they found supporting evidence of this as well. You can see on the left-hand side that less than 25% of the patients in this real-world data set from retinal specialist office in the United States received 10 or more, I should say, nearly monthly injections. So they appear to be undertreated. On the right-hand side, you can see that there's a correlation that they showed here between the number of injections in the first year with the visual acuity gains on the y-axis. And this is a great study done by Vivian Chin, who is a colleague of mine at UCLA when she was with Rishi Singh in Cleveland, where they looked at a large number of clinical trials, all with at least 3-year outcomes. And they looked at the ones here with 5-year outcomes on this slide. And you can see here that over a 5-year period of time, if they had about 10 or 11 injections, such as in the Bacoris study, there was a reduction even worse than what they saw at baseline. And when you look at the Horizon study, sort of in the middle of that graph, they came back to baseline. Not noted in this slide is the 7-Up study, which was 2 years beyond the 5-year follow-up in that Horizon study that they published there. It actually dropped back past the baseline. It got worse. And then when you look at studies like Peden et al., published in 2015, where they have 50 plus injections over that 5-year period of time, you can see that there's a significant mean improvement from baseline. So there's a really high correlation between the number of injections and the visual acuity that these eyes experience at a 5-year time point. And Charlie Wyckoff and his group looked at this in terms of an iris registry database, and they concluded, and I'll just read their conclusion, that the modeling suggested that more frequent injections were associated with better vision. Difficulty with continuous adherence to frequent intravitreal injections contributed to undertreatment, which resulted in less than optimal visual acuity outcomes. Again, supporting what I just presented to you from a variety of other real-world analyses looking at different databases. And here is some of the data from this Wyckoff study, where you can see here that as the mean number of anti-VEGF injections reduces out to year 6, so does the visual acuity. And phrased another way, as the interval becomes longer, the visual acuity drops here as well. Uh, in a different study done by Singh et al., you can see here they looked at a large number of eyes in the iris registry. They excluded eyes that did not have neovascular age-related macular degeneration, had certain visual acuity and age criteria, and they divided eyes into actively treated and not actively treated. And then when they looked at the actively treated eyes, they defined eyes as having sufficient treatment, which is 7 or more injections in the first year, versus insufficient treatment, which is less than 7 injections in the first year. And they found that the eyes that had sufficient treatment, not surprisingly at this point, given what I've said.
It's my pleasure to talk about the use of tyrokinase inhibitors in neovascular AMD. Tyrokinase approaches include biodegradable microparticles and implants. They've also had systemic treatments that have been tried, as well as topical. Currently, tyrosine kinase inhibitors, as OTX-TKI, uses axitinib intravitreal implant. EYP-1901 uses vorolanib intravitreal implant, and CLS-AX axitinib uses suprachoroidal suspension administered into the suprachoroidal space. GB102 uses sunitinib, which was an intravitreal suspension, which unfortunately broke apart. And because of the breaking apart of the material, it caused decreased vision. Though the OCTs remained stable, the visual acuity decreased, and this is not going on. There are a number of phase 2 and 3 trials that are under treatment right now. The biologic activity, as has been pointed out, is very similar to an anti-VEGF, though it's intercellular and actually impairs all the VEGF receptors that are tyrokinase, including VEGFR1, 2, 3, placental growth factors, rather than the extracellular blockage of PLGF, VEGF-B, and VEGF-A. And in this case, you get VEGF-C and D. There's good preliminary safety, and durability is greater than 6 months. The first one we'll discuss is OTX-TKI, axitinib hydrogel fiber intravitreal implant. This is sustained release, goal of longer duration without the need for surgical intervention. The goal of sustained release is anywhere between 6 and 9 months. That's their goal. It's an intravitreal TKI delivery, potential for broader anti-angiogenic profile compared to just anti-VEGF agents, which hit VEGFR1 and VEGFR2. It's the systemic TKI efficacy has been established in oncology. It's biodegradable polyethylene glycol-based hydrogel fiber containing TKI biodegrades via ester hydrolysis in the presence of water and is cleared from the vitreous. As long as you can see the implant, it is still eluting material. So it gives the investigator or the treating physician a chance to see if the material is going away. The first study that was done, a phase 1 study, took a group of patients that with subfoveal neovascularization secondary to AMD that had controlled fluid, meaning that the fluid had been treated previously. These were previously treated patients, and there was very little to no fluid left. They were given OTX-TKI at day 0, and a aflibercept was given 1 month later in the TKI group, as well as the aflibercept group. The aflibercept group received treatment every 8 weeks, as per the label, and the TKI was just followed. The month analysis was at 10, as well as month 7. The retreatment criteria were fairly loose: loss of greater than 10 letters from best corrected visual acuity, with current best corrected vision worse than baseline, or evidence of 75 microns of increase in the central subfoveal thickness from the previous best value, and a 5-letter loss from the best previous. This is a combined treatment or new macular threatening hemorrhage. Here are the results, and it's very interesting. If you look here, there are actually 3 lines One of them is the aflibercept in yellow. And then there's the TKI that had no rescue and the TKI that did have rescue. And at the end, you can see these are fairly straight lines. And the eventual result at 52 weeks was basically no significant loss of vision, as well as the CST, which remained relatively stable throughout the course of treatment. If you look at the phase 1 study at week 28, which would be basically 6 months after the aflibercept injection, 73% of the OTX treated patients were rescue free. And this maintained itself to week 40 and began to decrease after that. But even at week 52, 60% of the patients that treated with OTX had remained treatment free, rescue free. And if you look at the swim lanes of these patients prior to receiving treatment, you can see these were VEGF addicts. They had a very high need for anti-VEGF therapy. And you'll see two colors on the right-hand side of the screen. You'll see a green and you'll see a purple. The purple were rescues that were given but did not meet the criteria for rescue. The green did meet the criteria for rescue. And you can see the aflibercept down below receiving multiple injections throughout the course of treatment. Everything in a phase 1/2 study, safety is extremely important. There were really no significant problems. There was one case of endophthalmitis, which occurred actually following the mandatory aflibercept injection at month 1. It was reported as moderate, and the patient did return back to baseline once they were treated for this. All the events were considered mild, and there was increased intraocular pressure in the aflibercept group noted. This leads us to phase 3 trials. There are two phase trials undergoing evaluation at this time. We have SOL-1 and SOL-R. So the SOL-R treatment and SOL-1 are very different. SOL-1 is a superiority trial. In this trial, patients receive two treatments, a naive population at month -8, -4. Then they're looked at month at 0, and they receive either a OTX TKI or aflibercept, and they're followed until rescue is necessary. These patients have to have a great response to the previous two aflibercept treatments. They have to either come back with 20/20 vision or gain at least 10 letters to be eligible for the superiority trial or SOL-1. And they're evaluated at week 36, and they're also evaluated at the end of week 52. The non-inferiority trial or SOL-R takes those patients who did not get a great response in the first 3 treatments. They came in and they still had fluid. They did not get a great response. And then they were treated again 8 weeks later, and then 4 weeks later. And then they were divided into patients who received OTX on day 0, aflibercept 2 milligrams at day 0, or aflibercept 8 milligrams on day 0. The 2 milligram group was followed every 8 weeks, receiving additional treatment, and the 8 milligram dose was treated at week 24, 6 months after the first treatment. And OTX was also administered at week 24. These are ongoing trials, and hopefully we'll have results toward the end of next year. Vorolanib is an intravitreal implant by EYP-1901. It is a pan-VEGF inhibitor. It's a biodegradable intravitreal implant. They've had previously 2 FDA-approved steroid products. It's in the Duracert technology, and this is biodegradable, unlike some of the other steroid implants that left a hollow shell. It was tested as an oral agent in X82 for neovascular AMD in a phase 1 and 2 study. There was a biological signal indicating that exudative control with dose-dependent reduction was found, indicating that the drug definitely worked. It did get to the target area. However, there was liver toxicity, and the phase 2 was halted. Though fortunately, all the patients who had treatment, their livers did return back to normal. It is biodegradable. If you look at the ocular PK of EYP 1901, there's an initial small burst, and whether you have the 643 micrograms or the 900 micrograms, you can certainly see that there's high levels that are found in the vitreous and the retina in the choroid, with less being seen in the aqueous and virtually very little being seen in the plasma, indicating that probably will not be any systemic side effects from this treatment. It reaches steady state very quickly, and as you can see, it really goes almost 240 days before it starts to drop off, both in with the 643 micron, and it goes about 260 days if you use the 900 microgram. So the target tissues were all above the IC50 for both of these, indicating that we'll get a good response. The Davio study was a Duracet and Everolimus in ophthalmology. This is a phase 1 trial. 4 doses were given. There was a 440 microgram dose, a 1,030 microgram dose, a mid dose of 2,060, and a high dose of 3,090. There was only one patient in the mid dose. This was because one of the mid dose, there were uh, two particles that had to be administered, and only one particle came out. So that was the mid dose. It was an accidental dose. The administration of supplemental anti-VEGF therapy through month 6 was seen, and the ocular, non-ocular TAs was the primary endpoint. Here are the baseline characteristics. You can see patients receiving 8.76 injections per year about every 6 weeks, and predominantly female with visual acuity about 69 letters. And the mean CST was about 299 microns. This was in a previously treated group. And here's the phase 1 study. You can see, again, a straight line from the time that they were treated till the end of month 12. And you can see the CST remaining relatively stable throughout. Here again, a very high need group requiring a fair amount of injections to maintain dryness in the past. And you can see here the mid dose reduced the injection frequency by 87%. And this led to phase 2 Davio 2 study, where EYP 1901 at 2 milligrams, the low dose, or EYP 1901 3 milligram at the high dose was administered versus aflibercept. All patients received 3 monthly injections at day 1, 4, and 8. The EYP was administered at week 8, either the high or low dose, and the aflibercept continued to be administered every 8 weeks. These patients obviously had to have a response to anti-VEGF and a history of greater than 2 anti-VEGF in the last 6 months. The vision was 20/20 to 2200, and they excluded CSTs of greater than 350 or intraretinal fluid greater than 25 microliters. Here again, you can see the results here show the best corrected visual acuity to be relatively stable all the way across in all 3 groups, as well as a CST, which you can see in the gray line on the bottom. There is a sawtoothing that we see when aflibercept is given every 8 weeks, indicating that there is trough and peaks with treatment. The incidence of supplemental injection-free rates at month 8 was 63%. So 63% of the patients did not require an additional treatment. And this was actually carried out almost the same all the way to week 12. 52% of the treated patients did not require any rescue treatment at all. And the phase two Davio with the swim lanes showing, again, a great deal of need prior to the treatment and a 80% reduction versus the pre-trial treatment after the drug was administered. The key safety findings, there was no EYP-1901 related ocular SAEs or systemic SAEs, no insert migration to the anterior chamber. There was no case of retinal occlusive vasculitis, and there were no discontinuations related to the EYP-1901. 97% of the AEs reported were mild or moderate and generally were expected with intravitreal therapy. There were 6 participants with ocular study SAEs, none deemed related to the EYP-1901. This led to the phase 3 pivotal non-inferiority trials of Lugano and Lucia. You can see that it mimicked what was found in the phase 2 trial with 3 injections of aflibercept, and at week 8, the EYP-1901 2.7 milligrams was administered. Again, the aflibercept group was treated every 8 weeks after that. And the difference in this is at week 32, or 24 weeks after the last EYP injection, EYP-1901 was again redosed. The endpoint was a blending of week 52 and week 56 of the visions at that time. And again, the supplemental criteria decrease in 5 letters and increase of 75 microns, or a vision-threatening hemorrhage due to AMD on the examination. There's an additional treatment that is given in the suprachoroidal space. CLX-AX is a phase 1/2A OASIS trial. This is the injector, and if you go perpendicular and apply pressure, once you get into the suprachoroidal space, that space will enlarge, allowing the medication to actually go all the way around the side of the eye. This trial design was basically open label study. A primary endpoint was basically safety and tolerability of a single escalating dose. Patients had to have at least 2 anti-VEGF treatments in the prior 2 months, and that the reading center confirmed that they still had active disease and also that they had a response to treatment. The doses ranged from 0.03 milligrams to up to 1 milligram. And secondary endpoints were visual function and anatomy. And again, similar type of rescue criteria, loss of best vision greater than 10 letters, with exudation increase in the CST of 75 microns. Here again, these graphs are getting very similar to you because they all show straight line once treatment's been instituted. There's very little variation either in the visual acuity or in the OCT measurements. And if you can take these patients either with rescue or without rescue, and again, it shows a fairly stable treatment all the way across for the time that they were evaluated, which in this case was a little shortened, month 8. Here are the pre-treatments, no additional therapy at 3 months and 100%, at month 4, 91%, and at month 6, 73, and greater than that, 55% of patients did not require treatment. So by month 6, 73% of the patients did not require any rescue based on those criteria. This leads to the phase 2B Odyssey study, which again is very similar to what they did in the phase 1. Here you can see, however, that the aflibercept is administered day -4, day 1, and day 4, and then administered every 8 weeks after that. The CLS-AX 1 milligram dose was administered on day 1, and then again at month 24, at week 24. Here we can see again the best corrected vision has remained relatively stable with very little fluctuations either in the CLS-AX group or the aflibercept group, and the CST anatomy has remained stable, no change. So stable best corrected vision to week 36 in difficult to treat patients. Injection frequency reduced by nearly 84%. No ocular SAEs or treatment-related SAEs. CLS AX was well tolerated after redosing, and only a phase 2 trial in neovascular AMD with repeat TKI dosing and potentially de-risked the phase 3. Early phase differences, however, you need to, when you look at different trials, you need to know what the rescue criteria were. And CLS-AX demanded rescue if you increase the CST by greater than 100 micrograms. Um, and this is from baseline. And as you know, they may have improved after the aflibercept injections. EYP greater than 100 micrograms from the lowest CST for 2 consecutive measurements. And OTX TKI, there are no separate CST change criteria. Best corrected vision, greater than 10 letter loss from baseline in CLS. EYP 1901 is from the best corrected vision. So this is after they've received some of their aflibercept injections. OTX similarly, but had to have a current best corrected vision worse than baseline. And best corrected visual reduction of 5 letters from baseline, increase in CST of 75 microns was pretty much the standard across. Again, CLS-AX went from baseline, whereas EYP-1901, OTX, TKI, both were from the lowest CST. And again, if there was any vision-threatening hemorrhage, they were allowed to be rescued. So in summary, the TKIs for neovascular AMD are small molecules with pan-VEGF intracellular mechanism of action, different delivery platforms. However, they all showed similar results in keeping the CST stable and the visual acuity stable. There's clear proof concept of whether it's given systemically, intravitreal bioerodible, or in the suprachoroidal suspension. Currently, there's no evidence of any dose limit toxicities, and no one's reported any systemic findings. So how will TKIs fit into the current therapeutic landscape? Michael, why don't you present your case and we'll go from there.
Thank you, David. That was really a well-done summary of where we are with TKIs, and it's really promising to see that we have at least one early phase candidate and 2 in late phase testing. And it looks like they hopefully will pan out to be able to address the treatment burden limitation that I had outlined earlier on in this talk. And so we thought it would be good to show a couple of real world cases and maybe some cases from some of the clinical trials. So my case is what I think is fairly typical that retinal specialists will see in practice with regards to the limitations that we are talking about. So this is a patient I've seen for many years. I've seen her since she was transferred to UCLA. In her right eye, she had neovascular age-related macular degeneration. At the time of transfer, she had already had over 20 bevacizumab injections. Her visual acuity was 20/60 in the right eye, and we had scanned in the referring note that I had gotten. It was sent in on paper forms at that time. We scanned it in, and you kind of see there's some SHREM and some subretinal or intraretinal fluid there. And again, she had had 20 bevacizumab injections about every 4 weeks back in 2020. And I had given her, I switched her over to aflibercept every 4 weeks, and here on the right eye, you can still see some SHREM, but she's relatively controlled, but very dependent on the aflibercept injections. Here's her left eye as well, and I started her on this on aflibercept as well in the left eye. So she was getting bilateral injections, so very high treatment burden. And when we go more towards the 6 weeks, she starts to develop fluid, as you can see here, on top of the subretinal hyperreflective material. And I've even switched her over to some of the so-called second generation treatments. I started her on faricimab, and even on that, She's very dependent on the injections and very difficult to get her you know, independent of anti-VEGF injections in this right eye. So it's a fairly, I think, typical case, and certainly probably would have been eligible for at least one of the clinical trials that Dr. Boyer had just outlined. So that's we'll move on to another real-world case from Dr. Boyer.
Michael, thank you. That was a great case teaching us some patients just don't respond very well. This was a patient that I saw a number of years ago, an OCTA demonstrated small C and V. You can see it here. And this was basically going back to 2019. You can see the fluid here, extrafoveal. I thought, boy, we caught this early, and this is going to be an easy case to treat. The patient was treated with bevacizumab, and you can see over the year period, continued to have fluid. The patient was getting treated very frequently, did dry out in 2021. It looked much better, looked pretty good in 2023. In 2024, you start to see again, it's leaking off to the side, continues in 2025. Here you can see that there's some hemorrhage present. And you can see on this fluorescein, the hemorrhage blocking. There's a new hemorrhage, visual threatening hemorrhage. And this is in 2025 after, again, we've switched the patient over at this point to aflibercept. However, this patient received 80 injections over 90 months, averaging about every 38 days. So the patient went a little over 5 weeks. And because of insurance, Avastin or bevacizumab was utilized for most of the time. Finally, the Healthcare Institute allowed us to use aflibercept. The vision actually was 2100 when we started, was 2080 at the end. The patient's 96 years old, is having other medical issues, difficult for the patient to come in. And I think these patients who we were having difficulty either controlling or have difficulty in coming in because of other medical issues and would be good candidates for TKIs or longer acting delivery systems. I think we've all had patients that unfortunately became ill, and when they became ill, they didn't come in, and when they come in, now they've had irreversible vision loss. This may be saved by having these long acting delivery systems. So these are cases from clinical trials. This is the first case. Michael, you want to go through this case? This was DAVIO 2, as you remember. In DAVIO 2, these patients received injections at day 1, week 4, and week 8. You're the expert in reading these. What we tell the audience what you see.
Yeah, I mean, I think this is a it's sort of a prime example of how TKIs can help, right? So uh, in all of these eyes, there's a high treatment burden. The visual acuity is usually pretty good. It's sort of highlighted the two cases that we showed, certainly in my case, Dr. Boyer, a patient requiring anti-VEGF injections over and over again, but as long as you keep giving them the injections, you can preserve relatively good visual acuity, right? So I think this is a prime example of how TKIs, the whole approach, can be very effective here, because you can see at screening, this is a patient who responds to anti-VEGF. Their visual acuity is quite good. And then they have the aflibercept injections. They're still responsive. They're doing well. You can see, those little round circles are where they're getting the anti-VEGF injections at day 1, week 4, and week 8. And then the TKI is given at week 8, and you can see all the way out to week 32. If you look at the OCT, there's really very little change, very, very good anatomical control all the way out to week 32. And if you look at the visual acuity, it stays in the range of 70 plus letters. So this is sort of the holy grail. This is exactly what we need for these patients. And I like the way you had mentioned in your last case, there were two issues that I sort of highlighted at the beginning of the talk, which is a lot of these patients have financial issues, right? So your patient had to have Avastin, which might arguably be somewhat limited compared to what we have, but there are financial limitations. And if they were on a branded drug, there's probably some disincentive to come in. And you had also mentioned that there were some medical issues. So we're seeing these patients in a very limited way, but in the overall scheme of their life, it's very hard to get in. So if this became a real world situation where we could do this in the real world, this would be really ideal. So I think this is a good case from Davio 2, showing good anatomical and functional control with the introduction of a TKI at week 8.
Thank you, Michael. That was excellent. I think the one thing that we need to emphasize in all these cases that we're looking at, the patients had to come in fairly dry. They have to have responded to anti-VEGF therapy. If they didn't respond to anti-VEGF therapy, this drug probably all the TKIs will probably not be effective. So, though we have seen evidence now that a TKI alone can treat without having any additional anti-VEGF therapy that was shown earlier in the OTX. I think most of the studies today are looking at trying to dry them out and then maintaining them. This is an interesting case because you can see here on day one, there's fluid. There's fluid after the first injection of an anti-VEGF. There's fluid after the second injection of anti-VEGF. Perhaps a little bit of fluid after the third injection, as well as receiving EYP 1901, drying out at week 12, but then soon after, at week 16, you see fluid. However, as Michael pointed out, the visual acuity remained relatively stable. 72 letters at baseline. On day one, it was less than that, 68. And week 32, it was 69 letters. So the visual acuity remained relatively stable. I think we have time for one more case. Michael, if you want
David,
to.
can I just comment on that
Oh,
on
absolutely.
that last case? Yeah, it's a very interesting case. I think it's a situation that shows us, TKIs might not have to be perfect even to achieve what we're aiming for, right? I mean, there could be a little bit of fluid tolerance with the TKIs, and I think it also highlights some of what we've seen in the literature lately, which is compartmentalization of the fluid, right? That there might be some better tolerance for subretinal fluid rather than intraretinal fluid. And I think this is a good case that highlights that. If you look at the follow-up after week 8, uh, the uh, the disease activity mainly represents subretinal fluid. There's not that much intraretinal fluid, and yet you have relatively good visual acuity. So I think it highlights the point that if you're, with TKIs, we may not have to achieve perfect anatomical control, and then we can also recognize that there's compartmentalization of the fluid, and that might actually have some prognostic provide some prognostic indication in terms of visual acuity.
Thank you. We'll do one more case and then we want to have time for questions. You want to take this case? This is a similar case where a high dose cohort remained without supplementation for 12 months. Um, pa the patient was,
Yeah. I mean, the high dose, the higher dose here seems to obviously achieve at least control as good as the lower doses here, and it's really pretty impressive how long we're able to go out on this patient. I mean, of course, would have been interesting to see what happened to this patient before baseline, but we're assuming that, again, it was a high treatment burden case. I would like to have seen maybe how far they could have extended this high, but it's certainly impressive what we're seeing. If we assume that it's a high burden eye, this is very impressive in terms of the higher dose treatment in Davio 2.
I agree. Let's go. We'll skip this case. Go back. Um, so, what will guide the choice of anti-VEGF versus TKI? Where do TKIs fit into the treatment regimen? How do we consult patients and explain the rationale? Um, Michael, you want to take any of these in
Sure,
one?
sure. I think let's say we're in a world where the TKIs become widely available. I think it's going to be a very interesting question. I think, at least in the beginning, personally, what I would do is probably stick with the anti-VEGF first, just because I'm so familiar with the safety profile. I know it's got a great safety profile. We've done, tens of millions of these injections. And I think, I think at least initially the TKIs, I can see them being mainly as a rescue or a situation where we we have high burden eyes that we've just been talking about, and we need to try to reduce the burden. But I can even foresee a situation where, as we grow more comfortable with the TKIs and the safety profile of the TKIs, that they could be used even earlier on in the process. So you get a patient with treatment naive exudative AMD, and maybe we load them with one or two anti-VEGFs and put the TKI right at the beginning of the treatment course, and that might be a treatment paradigm that we follow as we become more and more comfortable with the TKIs following introduction. So as for the second bullet, I think I kind of answered that with my answer to the first one. And for the third bullet, how I would counsel patients is uh, similar to what I just said at the very beginning of this, which is we're going to have to get to know each other pretty well, right? You're going to have just a high treatment burden condition. You're going to have to come in. You're going to have to realize that you need frequent injections. But in this case, I might modify the statement at the beginning to say not only you're going to have high treatment, but I might modify it to say, I think we're going to have a high monitoring situation. We might not have to treat you as much, but I think monitoring and checking the OCTs, even with TKIs on board, is probably what we're going to have to counsel our patients.
I agree. I think that I would look at this as we have high need patients. I think there's probably between 10 and 15% of patients that cannot go 8 weeks. They go 4 weeks, 5 weeks, 6 weeks, some even going less. I think I would probably do these bad actors early. I think maybe I'll get them out 3 months, maybe 4 months. I don't think you're going to get them all out to 6 months or 8 months. But I would probably start with those. But I agree with you, as I become more comfortable with the treatment, I think once they dry out, this may allow the patients not to have to come in as often. So I think that we'll probably start with the people that we really have trouble controlling, but you do have to have a response. If they're not responding to the anti-VEGF, it's probably not going to work. Um, let's go ahead and try to answer some questions. And while we're getting the questions, I want to thank you for attending, and please claim your credit. I think we have some questions, Michael. I think we've answered some of those. I don't know if there are any. There's question is, we know that there's a need to continuously monitor and treat patients with neovascular AMD. Are there any biomarkers that you feel are particularly important with regards to continuous treatment? I think the biggest one is they have to respond to the anti-VEGF. I don't think we can figure out ahead of time who would be a good responder, who's not. We answered question 2, how would you incorporate TKIs into your practice? And we'll have several long-acting treatments available in the future, PDS, gene therapy, TKIs. Do you want to comment when you would use PDS or gene therapy versus the TKIs?
Yeah, I can also comment on the other one too in terms of the biomarkers, but yeah, I'll take the one first with regards to the other long-acting therapies. I think with With PDS, I think obviously it's available. It is. I don't know how much it's actually being used, but it's looking to address the exact same issue that we're dealing with here, which is the treatment burden. I think it has a role for certain patients. I think if they're at this point without TKIs being available, I think if you want to reduce the treatment interval, the treatment burden, I think it's a very good way to do it. I think you have to balance it against the fact that you actually have hardware in the eye, and there are some potential side effects. But I think right now it's certainly an approach that one can choose to reduce the treatment burden, keep the visual acuity good, and maintain good anatomy. With the introduction of the TKIs, there may be even less of a need to go to PDS, but again, that remains to be determined. With respect to gene therapies, they look certainly very promising. Most of them are using a biofactory type approach, and I think we'll have to see what the late phase testing results are going to be with that, but certainly very promising. I've participated in some of those studies. And I'm very optimistic about that. Going back to the question with respect to biomarkers in the neovascular AMD patients, I think it's those patients that have an anatomy similar to what I showed you in my case, where there's a large uh, volume of subretinal hyperreflective material. I find that tends to uh, have recurrences over time. And I think those are the ones that I have very keyed in on that need uh, certainly continuous monitoring and oftentimes continuous therapy. So I think those are the cases where I feel we really have to worry about long-term follow-up and long-term treatment.
There's one additional question from the on the chat. Do you think home OCT monitoring would dovetail nicely for follow-up with TKI introduction? And I think the answer is overwhelmingly yes. It would certainly change our paradigm from treat and extend to probably more of a PRN treatment. We would know when to bring the patients in. And as Michael pointed out, we could reduce the recurrence of fluid, which the up and down fluid will cause some problems. There was also a question regarding it works for neovascular AMD. Will it work for diabetes? And the answer to that is yes. And both company OTX as well as EYP are going to go forward to look at the diabetic population. I think that the nice thing about TKIs is the safety is excellent. You don't have to worry about inflammation. It's not a surgical procedure. So you can put that into your head when you're looking about PDS or gene therapy in relationship to TKIs. We're out of time, but I thank you very much for your attention. And thank you for staying and listening to this.
Thank you, David. Thank you, everyone.